Remember the headings. Headings remains the same. So what are the headings? Attitude, swelling, deformity, skin around the pathological area, muscle wasting, and limb length discrepancy in inspection. And when you do the palpation, remove the attitude and bring temperature and tenderness, that becomes palpation. Okay, we'll start it here. What are the areas to be inspected? There are certain pathology which may mimic the problem of the hip. It could be the hip joint, which is in the injury, could be the fractured neck of the femur. In disease, it is the disease of the joint itself. The another could be fracture or the disease of the greater trochanter. Disease could be the trochanteric bursitis, whether it is rheumatoid or whether it is tuberculous, but it is a different entity away from the hip joint, but still it will mimic the problem in the hip joint. There could be the third one, which could be the upper part of the femur, diseased or fracture. Either way, it will mimic the problems in the hip joint itself. So be careful, look all the three areas. So how to look at it? So first, attitude. So hip is extended, abducted, and because patella is facing directly upward, there is no rotation in the hip. Knee is extended and the ankle is plantar flexed. The attitude we have finished. For the swelling, we have recognized the three areas. One is there, for the hip joint, the area is femoral triangle. We know the femoral triangle base is made by the inguinal ligament, lateral border by the sartorius, and medial border by adductor longus. So this is the area of the femoral triangle. If there is a disease or the fracture, if the swelling happens in the hip joint, intra-articular swelling, it will be reflected as a swelling in the femoral triangle. Then we will be looking at the trochanteric area for any swelling. And the third is upper part of the right thigh I am looking. There is no swelling. Then deformity. For the deformity, there won't be any obvious deformity. So let us try to look at the fixed flexion deformity of the hip. How to look at it? So you have to look at the lumbar spine. So lumbar spine, if you look and put your fingers to confirm it, I am putting my fingers, and if it passes very easily, it means there is a space between the lumbar spine and the bed. It means the lumbar spine is unduly exaggerated. Can be confirmed by two means. One is putting your finger and seeing there is a space. Another is take out a torch and put it on from the other side. The light coming from other side, it means there is an exaggerated lumbar lordosis in that particular patient. If there is no space between the lumbar spine and the bed, it means the patient does not have the fixed flexion deformity of the hip. Second one, deformity, fixed adduction and abduction deformity is to be seen by looking at the level of ASIS. So confirm the level of the ASIS. If both are at the same level, you can confirm it. It means there is no fixed adduction and abduction deformities. ASIS is important in determining the deformities of abduction, and adduction one is to be seen. And why so? How to know the fixed adduction and abduction deformity in a particular patient? If there is a, say for example, this patient has got fixed abduction deformity. If it is more and the patient is lying on a bed, the leg will be outside the bed. They won't keep it like this. They want to make the limbs parallel. That is most convenient position for the patient. If the limb is in this position, patient cannot walk. For that purpose, they want to keep the limbs in parallel position so that they can walk. So how to make it parallel? So they will try to make it parallel. For that, this limb must come towards the midline. How it will come? There won't be movement at the hip towards adduction side. Say for example, if there is fixed abduction deformity of 10 degree, it will never come towards the midline or towards adduction. There may be further abduction possible, but not towards adduction. How can they make it parallel to each other? Let us see it. What they will do is, they will tilt the pelvis again. So it is away, then they will tilt the pelvis like this. Pelvis is tilted, pelvis can move. But in this process, what has happened? It was like this. Now it has tilted. The limb has become parallel. But see the ASIS. This side of the pelvis has gone up. How to recognize? This is the pathological side. If this ASIS has gone down, it means the patient has got fixed abduction deformity. If in a case there is a fixed adduction deformity, how they will make it parallel or limb straight? They will do just opposite. So it is like this, they will have to do like this. So what has happened in this procedure? This ASIS has gone up. So if this ASIS goes up on the pathological side, it means the patient has got fixed adduction deformity. And if this ASIS has gone down, it means patient had got fixed abduction deformity. So far we have seen attitude, swelling, deformity. Then for the skin, you will be looking on all these areas for the skin, for the signs of inflammation, ecchymosis. In the case of injuries, bruises, or in the case of the previous some diseases coming out for the chronic one, for the scars and the sinuses. All the three areas, femoral triangle, skin around the trochanteric area, and skin in the upper part of the thigh. For the muscle vesting, it is the gluteus which will be vested. You have to look at the gluteus, and then you have to ascertain the limb length discrepancy. So you have to close the gap between the limbs, and you have to look at the level of medial malleoli. Here both malleoli are at the same level, so there is no limb length discrepancy. Had there been a limb length discrepancy, this medial malleus up, then I would have gone for looking for the segmental shortening by ascertaining the levels of the superior pole of the patella. Superior pole of the patella, if suppose superior pole of the patella is also up, medial malleus is also up, it means shortening is in the femoral component. If superior pole of the patella is same and the medial malleus is up, it means the shortening is in the tibial component.